Hello, good morning. My name is Megan Rao, and I am a physician at NYU Langone Health in New York City. I'm also the facilitator for the Manhattan Thyroid ThyCa group, and so it's really my pleasure to be here today. I am virtual, and so if there's any questions, please feel free throughout with the microphone if there's one in the room. Don't hesitate to ask questions. If you are watching online, you can put your questions in the chat box as well. So the talk today is talking a little bit about palliative care and hospice and what is it and what are some of the services provided and when is it potentially time to talk about palliative care and hospice. So just trying to think a little bit to yourselves, what do you think of when you hear of palliative care and what do you think of hospice? A lot of times there's a lot of misconceptions about what palliative care means. This means that somebody is perhaps giving up treatment. This is something that somebody is dying in the near future or at the end of their life, and that's the only time palliative care is needed. But that's not the case. You may also have heard palliative care referred to as supportive care, supportive oncology, or a symptom support team. There's many different names because there has been such misconceptions around palliative care. There's been a trend to use some new terminology to talk about the services that we provide. And I want to show this short video. I think you should be able to hear the sound that gives a little bit of an overview of what to think about when you're thinking of palliative care. We'll skip that, but there is a link there. And really this video is just showing you that you can kind of see on the image that is still up on the video. What it's looking at is you are here and then palliative care provides additional support to make sure that your care is upheld. And a little bit about palliative care and hospice, going back to the history of the field is helpful in putting in some of the context and where we are today. So Dame Cicely Saunders, she is the woman in the red jacket on the top of the screen. She's somebody who we consider the founder of our modern hospice and palliative care movement. And she is somebody who is in the UK, and she started her work and founded St. Christopher's Hospice in London. And this opened in 1967. So in the realm of medicine has been around for centuries. But if you think about palliative care and hospice, this first hospice hospital opened only in 1967. And that brings us then over to the United States. Our first hospice opened up in Connecticut in 1974. So again, not very long ago. In 1983, that is when the government introduced hospice as a Medicare benefit to provide that care and cover it through an insurance coverage. And then in 1987, this is when hospice and palliative care became a specialty in the United Kingdom. And it wasn't until 2007 that hospice and palliative care were recognized as medical specialties in the United States. So this is something that there have been physicians for a significant amount of time, but as a specialty of palliative care and hospice, it's relatively new. That has been here just really recognized in the past 20 years. And the woman on the bottom right is Diane Meyer. She's a physician, and she's one of our modern leaders and founders of palliative care in the United States. And she's a tremendous advocate for patients and for the field. And this is a quote. This is by Dame Cicely Saunders, and she says, "You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." So her big philosophy was continuing to uphold the quality of life until the time comes when somebody passes away. And when we think of palliative care, this is a definition for the Center to Advance Palliative Care, is really like and is used widely in the field. And palliative care is specialized medical care for people with serious illness, and it focuses on relief of symptoms and stress of that serious illness. And the goal is to improve the quality of life of not only the patient who may have the illness or the disease or the diagnoses, but it's the patient and their family. And then palliative care is provided by a team of clinicians. This includes doctors, nurses, social workers, spiritual care, and others, all working together to provide that extra layer of support for patients and for their families as they're going through the disease. And it's appropriate at any stage and any age. Palliative care can be provided. And again, this is something that is not only end-of-life care, this is something that is provided alongside care that somebody may be getting, including curative intent. And I do want to go back to some of the science and some of the impact that we have seen. Numerous studies have shown that palliative care improves patients' quality of life, and it also lowers their symptom burden. This is a really big study. This was in the New England Journal of Medicine in 2010. And this is a study that shows there was always concerns that if it's palliative care, you're giving up and patients are not going to live as long and they're going to receive less care. What they saw in this study, this was performed in patients with lung cancer, and they took patients in an oncology clinic and they said, we will use the regular oncology care, the regular treatment. We'll monitor that group of patients. And then we're also in a separate group of patients. We're going to do the usual care, but we're going to have them meet with a palliative care team very early, soon after they've received their cancer diagnosis. And what they found, and what the graph is showing up here on the top right, is this is looking at depression scores, anxiety scores, and also looking at how they are before and after. And what we saw is that with the usual care, the patients had more depression and more anxiety. So in the group that had palliative care intervening earlier, there was less depression and less anxiety. And we also saw that they had better quality of life scores. And then astonishing thing that really surprised everybody and is really something that we pride ourselves in the field is that even though there was palliative care involved, and a lot of palliative care has to do with potentially people who have issues with end of life, what we actually saw was a longer survival. So the patients who received palliative care survived longer than those with usual care. So this is something really showing and putting a little bit of a silence to the argument that we're going to be perhaps giving up on patients. This isn't the case. We continue to be there with patients and their families throughout their trajectory of care, and it really does improve their quality of life and their symptoms, and it did see a longer length of life as well. And when we also think about palliative care, not only from the patient and family perspective and what means most to them, we also see from a financial impact that palliative care also reduces avoidable spending and utilization of services. So just because we can do a lot of things doesn't always mean that that aligns with what matters most to patients and to their families throughout their care. And so what these arrows are showing is that different settings of where palliative care can be provided. So they can be provided inpatient, which is in the hospital type setting. They can be provided outpatient, which is in the clinic setting. They can also be in places such as skilled nursing or nursing homes, and then in the home. And what we saw across all of these settings where palliative care is provided is that it had decreases in the cost and the spending for care. And again, this didn't see a decrease in the quality of care or life, but it did see that financial impact, really showing that we make a difference in many different ways. And that really those cost savings are important for health systems, but really those are important for patients and their families as well. And going back to this definition of palliative care, thinking about who are those team members and what does palliative care provide for patients that results in this improvement in their quality in life and an improvement in their symptom burden and improvement in their cost savings. So when we think about palliative care, team is one of the most important parts of palliative care. There have even been studies done that tested using just one person to provide some of the services, and they found that that wasn't effective. What is really effective is using the team approach for palliative care. And what that looks like is there are many different providers from many different specialties. So you have a physician who can help with prognosis, some of the medical interventions, treatment of symptoms. They can serve as a team leader in certain situations. You also have advanced practice providers, so nurse practitioners, physician assistants, who are able to deliver the direct patient care as well and collaborate with the rest of the team. Important members of the team are the social work. These are social workers are helping with social determinants of health. They're helping with coping. They're helping with talking with family and identifying resources. Because a lot more to someone's care is how are they going to get it? What are some of the barriers for receiving care and helping to work with that? And social work also provides legacy work, working with families and patients if they want to continue and perhaps leave a legacy behind, whether that's their story, whether that's a momentum of a handprint or a thumbprint, things along those lines. And also spiritual care. This is something that is integral to the practice of palliative care. And it's really important because we focus on the entire patient, the entire person and family. This is really mind, body, soul, really making sure we encompass everything. And the chaplain or spiritual care provider is able to provide services doing an assessment for spiritual distress, helping to really facilitate a lot of questions that may come up as the patient is going through their serious illness and helping them to cope and support with their family. The spiritual care is non-denominational, and it is a lot of time paired with whatever faith someone identifies with, or it can be something that is just very broad, if that is what the patient is. So we try to match it to what the patient's spirituality is. And when we think about the palliative care assessment, what we're thinking about is we're thinking about the whole person. This isn't just the specific disease, and really changing that mindset of this is somebody who has this is a 67-year-old person with thyroid cancer. No, this is really looking at somebody who is that person, and they may have the disease, but what other things are impacting them and impacting their quality of life. And we really want to focus on, again, the patient and their family or whoever their support system is, because we know that it's not just the person who has the diagnosis. It really impacts, and it's wide ranging on who it impacts, and then how care is delivered takes that team approach, including family members or friends. And we focus on multiple domains. So this is not just the pathophysiology or the way that the disease works in the body. We're also thinking about how are other things impacted? How does this impact somebody's social interactions? Perhaps this is something that they felt fine before, but now as they're going through treatments, they feel really tired. They're not going out. So now they're feeling lonely and isolated. How do we help address that? And we talked a little bit about spiritual care. And we also focus on what we call advanced care planning. So this is something that is important for any stage of disease. This is not just meant for someone who is potentially facing the end of their life. This is really thinking about what are things that are important now and for anyone at any stage of disease. Palliative care clinicians are experts in several different areas. And we talked a little bit about the whole person assessment, but also thinking about what are some of the symptoms, whether these symptoms are pain, nausea, vomiting, dry mouth even. What are some of those symptoms? Depression, looking at those and managing those. Thinking about communication. How is this someone, if there is some bad news, how do we talk to the patient about that or the person? How do we communicate what is most important to them and clarify what their goals are? We work with care coordination, making sure that all of the providers who are involved, if this is perhaps an endocrinologist, an oncologist, a radiation doctor, a palliative care, a primary care doctor, how does everybody get on the same page and make sure they have the information and make sure that the patient's goals are being met through communication? We also work with the emotional, spiritual support, and there's a lot of ethical issues that may come up when patients have serious illnesses, helping to work with patients and clinicians if those issues do come up. We work a lot with prognostication. I think the first thing or a lot of things that people think about when they hear something such as the word cancer is, what does that mean? How long do I have? Those type of questions. So really trying to work with patients and their families and the clinicians, if that's something they're interested in, getting that information for them in regards to prognosis. And then our role also continues with grief, loss, whether this is before something has happened or even if this is after somebody has passed away, continuing to follow and support families as they go through this entire process. And when it comes to symptom assessment, one of the things that is really important is doing a complete symptom assessment. A lot of times, if somebody has a specific disease or diagnosis, the symptoms are targeted around that disease only. So if this is somebody who has something, perhaps maybe pain is the only thing that someone is talking about, or maybe if it's an illness where their breathing changes, it's only focused on. What we really want to make sure we do as palliative care providers is that when we do a complete assessment, we are asking for a wide range of symptoms because we want to make sure we ask. A lot of times, patients may not be able to tell, they may not even know. And that's something we want to ask them. So if it is there, we can look at treating it. When it comes to depression, especially in a cancer population, it is something that a lot of people suffer with is depression as they're going through treatment. And a lot of times this is overlooked and it's not treated, partly because it's not asked about. And so this is something that we want to make sure we address. Also, anxiety and stress as somebody is going through their treatments. Or is this something that it's fatigue or they've lost their complete sense of well being? How do we then do an assessment so that we can make targeted interventions to improve those different domains in order to improve their quality of life? And the way that we do that, traditionally, a lot of people think if you're seeing a doctor or a physician or you're going to a hospital, you're going to get prescribed medications to make you feel better or treat a symptom. We know that medications work on maybe the specific location of the disease. We also know, though, that is more to this. And medications may work one way, but we have a modality of other interventions that can help patients as they're going through this. So things from physical therapy to acupuncture, and some things that people may not think about a lot. And what I'm showing on these pictures are looking at maybe some of the things that are not as common or not as traditional when you think about receiving medical care. So music therapy, pet therapy, massage therapy. These are all things that are another layer of support we can provide to patients as they're going through their treatment. And really, these can make a much larger impact a lot of times than even the medication. And the side effects are much less when you're thinking about these interventions. And so the picture on the bottom right are miniature horses, and that's actually a form of pet therapy. During my fellowship in palliative care, I was doing my fellowship training. We actually had somebody who came in and we were seeing her for palliative care, and she was going through some cancer treatments. And she was very much a big equestrian. And one of her last kind of wishes was she wishes that she was able to interact with the animals. And so we actually found an agency that does pet therapy with miniature horses. We weren't able to bring a full-size horse into the hospital, but we found the miniature horses. And so we were able to bring those in. And she was able to have some comfort and support from that, whether that's the nuzzling of the hand, the petting of the fur. So I think pet therapy is maybe something that's not traditionally thought of, but that's also another part. And then also yoga therapy, and that's what the picture is up on the top. So there's a little bit of thinking outside of the box when it comes to palliative care, not getting stuck in the traditional, you have this symptom, we have to give you a medication for it. But really thinking about, you have the symptom, does it need a medication, or are there other ways that we can help try to treat and assess and make sure that we're improving your care? And something that we deal a lot with that sometimes gets glossed over, but is incredibly important, and I'd almost say one of the most important, is really thinking about somebody's emotional and spiritual well-being when they're going through a serious illness. And not only theirs, but their families as well, or their friends, or their support system. And when it comes to spirituality, what this really is this is the deepest part of who we are, the concern with ultimate questions, the need for finding meaning, purpose, and fulfillment in life, suffering, and in death. So this is not just something that somebody, a particular religion or a faith. This is really thinking about more than that and encompassing who a patient is or who that person is. And this is where our spiritual care, our social workers, our chaplains, whoever it may be, really are helpful with our patients and coming in and answering some of these questions, and maybe not even getting a specific answer, but even just talking through and assessing it and finding out what is important to the patient. And really making sure that if there is some concern for spiritual distress or questions, how can we help through prayer, through support, through even maybe getting more information from a medical reason or medical perspective that can help alleviate some of that distress. And the chaplains or the faith leaders or the spiritual counselors, they can help from everything from doing life review to prayer, even working on anticipatory grief. So this is grief maybe before somebody ends up dying from their illness. So thinking about beforehand, what are some of those things? And then also making sure if there are any religious traditions or rituals that are important, making sure that those are observed and known throughout the course of the treatment. And the figure on the right is just showing a little bit more of some of the additional layer and support and things that can be provided when we're addressing spiritual care and well-being. And a lot of times patients may have what we call existential distress. And this is really driving from that emotional or spiritual, or there's another part besides just the physical disease process that's happening when somebody is going through a serious illness. And when it comes to advanced care planning or communication, palliative care is a field that is trained in this. And what is most important about this is, especially now with the state of medical technology and care, we can do a lot of things for diseases or a lot of treatments, a lot of medications. But the big part of that is making sure we put it into the context of, are our treatments aligning with what matters most to a patient? And how do you know what matters most if you don't ask a patient? And so one of the things that we really want to do whenever we're first meeting a patient or caring for them is really getting to the heart of what is most important to you. And one of the things that we think about is really looking at concrete functional things. Is it important for you to be with your family? Is it important for you to be at home, to be outside? What are those things that bring your life meaning and quality? And how do we make sure that the treatments we're offering or providing are really aligning and trying to make sure we achieve those goals? Because everybody has a different version of what that means to them. And we also help with some of the logistical things. So things such as a healthcare proxy, which is somebody that a person appoints to be their medical, to voice their medical decisions in the event they can't. So to speak on their behalf for what their wishes are. And we really help and counsel that not only appointing somebody to be your healthcare proxy, which any adult, we recommend any adult appoint somebody to be their healthcare proxy, but then going a step further and talking about what is most important to them. So that way, if that person ever is needed, they know what to talk about. And we also help with things called MOLST or POLST forms. This depends on where somebody lives, on what it is, but the MOLST form is a medical order for life-sustaining treatment. So this is the form we have in New York. POLST is another form that is also across the country. Some other states use the POLST form instead. And what these forms are, these are specific medical orders that describe treatments that patients may want or may not want. For example, somebody may not want CPR when it's approaching their end of the life. That's something that can be specified. Maybe somebody doesn't want a treatment such as dialysis. That can be specified on these forms, and they are a medical order. And these are forms that are filled out with a clinician or with a medical provider to go through and talk about those. And these are really intended for somebody who we think is in the last year of their life. So this is not something that we recommend everybody has a MOLST or a POLST, a healthcare proxy. We recommend everybody have one versus a MOLST or a POLST is a little different situation. We also help talking with patients on what are the risks and benefits of the treatment options and how do those align, again, with what matters most. So anchoring back on the patient and their care, and how do we make sure that it's individualized to what is so important to them. And then we provide that extra layer of support. Maybe it's just talking through the information. Maybe it's asking questions. Maybe it's trying to get additional information that somebody may not have heard or may not have received before. So how can we help facilitate that for patients and their families? And when we think about palliative care, how can somebody receive palliative care if that's something that they're interested in? There's several different ways that palliative care can be provided. So this is something that if somebody is interested as a patient, we recommend asking your primary care doctor, your endocrinologist, your cancer specialist, asking them if they can refer you to a palliative care provider. Also asking if somebody's in the hospital, asking the hospital team if they can have that provider referral, or even calling the clinic yourself and asking, can I be seen in the clinic? And a lot of things after the COVID pandemic, what has happened is telehealth has been more accessible. So even if this is something that there's not palliative care, maybe in a more rural area, telehealth options have really opened up this ability for patients to be able to receive care. And also telehealth options, if somebody's not feeling well and doesn't want to go to multiple appointments, can be a great option for palliative care to be involved. And then the question is always who pays for palliative care? So palliative care is covered by most major insurances, and it is definitely covered by Medicare and Medicaid. So one way to figure out if it is covered is to search your insurance website and search for or ask for a palliative care provider in your network to see what is covered. This is a website, Get Palliative Care, and this is a website .org. And this is a website that actually has the ability for you to search for palliative care providers in your area. So this is something that you can type in your zip code for your state. If you wanted to look for somebody in an office or in a hospital, wherever the setting may be, you're able to specify that as well so that you can find somebody for either yourself or for your loved one and to try to get them involved in your care. And when we think about palliative care, we think of palliative care as an umbrella term. So this is that philosophy of care that is looking to improve somebody's quality of life while they're going through their serious illness, any age, any stage. And this is something that is in this picture, it's that bigger bubble. It's thinking about how do we maximize the quality of life? What symptoms do they have? How is their psychosocial support? All of those things. And within that, for certain patients, when the time comes, perhaps this is when they are approaching their end of life, thinking about other additional services. Is this something that we need hospice services to get involved in? Is this something that we need to think about shifting our focus from trying to cure to a disease to really focus on aggressive symptom management and support and maintaining quality of life until the end? And then there's also the very end when somebody is close to the end of their life, providing care at the end of life, specifically the terminal care, having somebody go through that process, trying as the natural process occurs, trying to make sure that the patient is comfortable, ensuring that they're comfortable, and really trying to ensure that wherever they had wanted to be, whether that's in home or if it's in a hospital, that we're honoring them until their last moment. And so that always brings up a lot of questions about what is hospice versus palliative care? Again, palliative care is the overall, and hospice is one kind of segment that we do specialize in as palliative care providers. They both have interdisciplinary teams. They're both focused on patients and their families, so the whole unit, not just one disease or patient. And where they diverge is hospice is a Medicare benefit, and palliative care is really a specialty, so that overarching specialty for providing care. And hospice is a insurance benefit through Medicare. And because it is that insurance benefit, really looking at the requirement that if the disease trajectory, if it continues on its normal course, if that prognosis is less than 6 months, that is one of the qualifying criteria for hospice that must be met. Because again, it's an insurance benefit. Whereas palliative care is any stage of disease. So this is any stage of disease, regardless of prognosis. And a lot of times we're very excited when patients can graduate from palliative care. They have maybe their cancer diagnosis, they receive their treatments, they have some symptoms that we support them through. We help them with their family, talking about the serious illness, and then they receive their treatment, they're in remission, or they've been able to get it treated and they're stable. Then we graduate and we say, it's been great working with you, but we don't need to see you anymore and continue to live on the rest of your life. And so I think that's one of the biggest distinctions between hospice and palliative care. And both can be provided in many different care settings, whether this is home or in a hospital or a facility. And again, palliative care is really making sure that we are following along with the patient, whether their intent is for curative intent, whether this is for life prolonging, or if this is something that it's focusing on symptom management until the end. And then speaking a little bit more about hospice and what that entails for patients and for their families, is it's the same philosophy of care that Dame Cicely Saunders, we talked about in the very beginning, and it's really focusing on comfort and quality of life for the time remaining before someone dies. And a huge part of this is supporting the family and the care and the whole care team for the patient as they're going through this process. And you can see on the graphic on the right, what this is that you have the patient in the center, but you can see how much is impacted and needed when caring for a patient that hospice is able to provide. So they're able to provide a physician or a nurse practitioner, they have counselors, they have volunteers, they have other services, including social workers and nurses, to make sure that the patients, again, that holistic mind, body, soul, everything is encompassed and cared for. And it is an insurance benefit, so they do provide medications to make sure somebody is comfortable and medications that are treating symptoms are covered under the Medicare hospice benefit. as well as medical equipment, and then bereavement services. So this is something that is unique to hospice and palliative care, and especially hospice. They provide services and follow up with the family members or support systems even after the patient dies. The duration depends a little bit on the agency, but it is afterwards. They continue to provide the services for family members as they are going through the grieving process. And one thing about hospice is that there's many different settings that can be provided in. It can be provided in the home setting, in the hospital setting. There's certain facilities or hospice homes that can provide the care, and also nursing homes can provide it. And this is something, though, again, that it's insurance benefits, so it's less than 6 months. It can be renewed. So I put the statement of Jimmy Carter. So Jimmy Carter, President Carter was enrolled in hospice in February of 2023. And he continues on hospice now. So he's 8 months after being enrolled. So you may say, you just told us you have to have a prognosis of less than 6 months, and it's 8 months. So how can he still be enrolled? Well, this is one of the things you give your best estimate at the time. If someone ends up living longer than that 6 months, they're able to renew that benefit and be reassessed to continue to receive those services. The one most important thing, and I think a big misconception of hospice services, is that hospice does not provide 24-hour, 7 days a week care, so 24/7 care at the home in regards to having a person there. What they do provide is they provide an access line. It really requires a family member, a friend, or a support system, or even private hiring if somebody needs to be there 24 hours. And so that's one of the big things that a lot of times can be tricky for patients who want to remain at home at the end of their life, making sure that they're able to have those supports there if they do need that 24/7 care. So there are ways, and again, that's where their social worker comes in and can help with some of the resources or being creative and how do we make that happen for the patient or their family. These are some of the resources that are available online that have been really helpful, and they are directed towards patients and their families. Getpalliativecare.org, that's where you can find the provider registry. You have the Center to Advance Palliative Care, or CAPC. This has information for providers, for caregivers. They also have frequent webinars for caregivers or for patients. And they have several educational videos, including podcasts and a blog about the different aspects of palliative care directed towards patients and their family. There's also Caring Info. This is a program of the National Hospice and Palliative Care Organization, which is a research organization promoting palliative care and hospice. So caringinfo.org. This is another great website that is for patients or their family members or a caregiver, anybody looking to get some more information about what services can be provided. And then the last one is prepareforyourcare.org. I really like this website. I'm also a geriatrician, and so this is something that we talk a lot about: what matters most, what is most important. A lot of times someone may say, well, what do you want? And so this is a website, Prepare for Your Care, that I encourage families to go on it together and fill it out together. And it walks somebody through what are some of those decisions that might be important or might come up, medical type decisions that may come up in the future, whether this is somebody who is older or if it's somebody with a serious disease. What are some of those treatments? And start beginning to, in a kind of a moderated, prompted way, to frame that discussion of what is most important to you, and what treatments or care or interventions may be acceptable and which ones may not. And so this is a great website. There's several. If I was in person, I would have had the brochures, but there's some brochures there as well. And it's online, and it walks you through those discussions and how to have those discussions. And so that is it. So I am happy to take any questions that anyone may have, questions, comments at this time. And thank you to everybody for allowing me to speak at the conference. It's really been an incredibly rewarding and an honor to be involved with the ThyCa organization. And I'm really happy that I'll be able to present today. I do wish that I was there in person, but I'm happy at least get to present. Thank you.
I have a question for you, Doc. I'm a
Mhm.
patient. I'm stakeholder patient on a palliative care via telehealth research project, and I'm wondering what your thoughts on palliative care via the telehealth system.
So I think with palliative care and telehealth, it definitely has opened up access to people who may not be able to get to a clinic or see someone in person regularly, especially somebody with some serious illness, if it's difficulty to even logistically arrange transportation back and forth or if someone's too tired. And so I think telehealth has really opened up the accessibility for palliative care. I do think that there are some things that are you can get a lot of things through telehealth. There are some things that I think it perhaps is not there and maybe won't be there. I think when you're having conversations or you're talking about serious things, even the therapeutic touches in, let me hold your hand as we're talking about some of these serious things or doing an exam. Those are limitations for telehealth. So I think it is a really great option. And doing an assessment and making sure we can talk about some of these things. I think there are certain limitations to it that I think we just have to continue to be creative and try to work around. Thank you for your question.
Morning, Megan. It's Jeff.
Good morning. Hi, Jeff. How are you?
Good.
Doing well.
Thank you for a great informative presentation.
So one of the questions is, when is it appropriate to pursue palliative care referral? Only with severe pain. So this is something that for a palliative care, what we've really seen in the literature is that earlier palliative care interventions really do impact a patient. So getting palliative care involved early on, even if this is just doing something such as the introduction or somebody has recently had a diagnosis, getting palliative care involved to do some of those assessments, not waiting until somebody has severe pain or has severe symptoms, or to a point where perhaps curative treatments are no longer available. And so, really moving this forward in the care closer to the time of diagnosis to do those symptoms and then continue to manage and check in whenever things change or there's been a clinical change to be able to check in. So, I would say that my thought is always if you're getting a diagnosis and there's any kind of distress or any kind of concern, getting palliative care referral early, getting established, and maybe you don't need to go back for some time, or maybe you need to go back, but I think earlier the better. How would a person know it is time to seek palliative care? So I think that's one of the things, if somebody is thinking about it or even curious about it, that would be a time. And there has been a lot of move, especially with the field becoming, again, it's still relatively new, but I think more people realizing that palliative care is not equivalent to only end of life care. Palliative care is much more than that. And so thinking about if this is somebody with a diagnosis and they're going to be receiving treatments, and even with that curative intent, that's a really important time for palliative care to be involved. If there's some symptoms that perhaps aren't being controlled, or there's quite a few things that are really impacting somebody's quality of life as they're going through these treatments, I think that's a really important time to ask your care team, what about palliative care? Would this be something that referral could maybe even just help do an assessment and see where to go from there?
Thank you, doctor. I worked for hospice in Denver probably 15 years ago. And one of the things that I found quite frustrating and just to be able to come up with the right words, maybe there's a pat answer. And I was thinking about it the other day as my son-in-law's uncle, he just passed away in hospice, actually in care in the Denver hospice. And two of the nurses, they were talking about the end of life, and they were talking to the wife. And so we were all there. And which I just think that's so inappropriate. How do you tell family members with just something very, very short? Most of them seem to understand, that they really can't hear you. They may look like they're just taking a nap, but they're coming to find out that most of the time they know exactly what you're talking about. How do you do it without being, just condescending, and just say it so nicely so the family is not, the feeling uncomfortable or anything, apart from saying, would you mind taking this conversation out into the hall or wherever? So any help on that for future?
Yes, absolutely. So one of the things and one of the fields with palliative care, we get extensive communication training. And to exactly what you said, it is so important. I work in the hospital setting, and I end up working with a lot of patients who are in the ICU or they're maybe a little bit confused in the hospital. And a lot of times it is going to be the family member who's there helping, again, serving as that healthcare proxy or a surrogate decision maker, helping to make some of those treatments. And one of the things that I always do, and the first thing I do, is I always go and introduce myself to the patient, whether they are awake or not, because I don't know how much they're hearing or understanding. And that is so critical. I think in some of the ICU studies, what they've seen is that someone may be perhaps on a breathing machine and sedated, then they recover and they recall conversations that have been had. And so I think applying that to say, we don't know what somebody is going through or how awake or alert they are. So the first thing I always do is introduce myself to the patient and then let them know I'm going to talk with their family member. And then really ask the family members, do you want to talk? We're going to talk about some things. Do you want to talk in the room? Or I think maybe we should talk outside the room, and we can always come back in and give the person an update or the patient an update to talk about some of those things. And even when talking with family members, really one of the beginning things is, how much do they want to know? How much details do they want to know? And a lot of times, if it is something surrounding prognosis or what may be coming next, everybody has a different understanding, different experiences, different perspectives on things, especially when it comes to end of life and dying. And so really trying to make sure that instead of just giving all of the information, making sure I understand first, how much do they want to know? How detailed do they want to know? And offering and asking, would it be okay if I share prognosis? Do you want to know what it may look like at the next step? Do you want to know what the symptom to look out for may be? Do you want to know some of the ways I'm assessing or the treatments? And so it's a lot of meeting the patient or even the family where they are in the situation. And especially we get communication training when it also comes to children as well. So a lot of times we may have a family member who's going through a serious illness, and they may have young children, or they may have adolescent or teenage children. So making sure that we are respecting what their wish is, also encouraging though to make sure that we're providing the information to children on the level that is developmentally and age appropriate for them. And so really when it comes to the communication, it's again, including the patient first and foremost, if they're able and they want to be involved, and then being aware that we don't know how much they're hearing, understanding, comprehending. And we do know that even if someone's not comprehending, we do know that voice is a lot of time comforting for somebody. And so for me, that's always checking in and asking, and then always coming back into the room if needed, or if it's at the house, maybe having a phone call or speaking outside the room before coming in.
Thank you very much.
How serious is the possibility of addiction to pain medication? So thank you for your question, Jay. So this is something that we're dealing with a lot, especially in the time and the setting of the opioid crisis or the opioid epidemic that has been going around. There's been a lot of concern about how do you treat someone's pain and symptoms, and what about the addiction potential to medications used to treat those pain and symptoms, such as opioids. And so a lot of things, again, what we're doing with palliative care is doing that whole person assessment, So taking into account what their physical symptoms are, but also what are some other things going in their life. And when we're thinking about the addiction to pain medication, one of the things we're looking at is what is some of the history or what are the risk factors that someone may have that predisposition to becoming too addicted to things. Such as thinking about has there been a trouble with alcohol addiction, or has there been a trouble with substance or drug use addiction, things like that. What are some of the factors? And really making sure that we're assessing what is the pain and what is the pain from and what is the type of pain. Because when somebody has legitimate pain and we're using the medication at the appropriate doses, it's working to treat the pain. A lot of times where there's concerns about addiction is really when somebody is using the pain medicine to get different effects or to get the euphoria or get some effects of being high or different things like that. So when there's actual pain and we're treating the actual pain receptors, that is one of the ways that we are assessing for addiction. And then looking at what are those other treatment options. So not just throwing a medication at somebody and saying, we'll see you in 3 months, but really saying, let's try this medication. Let's also try some massage therapy. Because a lot of times maybe the change in position or massage of the muscle is much better than even the medication we can give. Or what type of pain is this? Is this a type of pain where we need a medication such as an opioid medication, so something that's morphine? Or is this something that it's actually more of a nerve pain and we have other medications? We have nerve medications that can help with the pain much better. So really keeping aware that there is that potential for addiction, but then also making sure we're doing that full assessment so that we can target the pain in multiple ways to best achieve it for the patient, and then continuing to follow up and check in on them. I will say that with the opioid epidemic and crisis, there's been a lot of heightened awareness. There's been a lot of movement to stop prescribing opioids. I think as palliative care, sometimes we find our position in advocating for opioids. Even if somebody does have a history of something such as addiction, if they have a new diagnosis of cancer or serious illness and they're having very real pain, we still need to treat that. And a lot of times that may mean using opioids. And so working with the care teams on advocating for symptom treatment in a safe and responsible way, even if somebody does have a history of addiction. And then another question I have is, what are some of the difficulties that a palliative practitioner encounters? I think one of the biggest barriers is really the misconception of the field, and that this field is only meant for somebody who is at the end of their life with a terminal diagnosis. And this is something that we've seen as we move it further upstream, we can really impact the quality of life while somebody is going through their treatment. And sometimes the thought is, oh, I'm going through this treatment, I'm going through chemotherapy, I'm going through radiation therapy, it's going to suck, I'm going to feel terrible, and that's just part of it, but this is how I have to get through it. And really trying to reframe that and saying, yes, you can continue to go through these curative treatments, but we probably won't make you feel 100%, but you don't have to feel completely awful. There's ways and there's things that we can do while you're going through this to support you. And I think one of the other, difficulties that we get is that maybe the provider, whether that's an oncologist, an endocrinologist, a cardiologist, a hospital doctor, a lot of times they say, well, I don't want to bring palliative care in because they're going to give up hope. And I think really trying to shift that framework and saying that we are maintaining hope and we're making sure that we're aligning the care with what's most important to the patient. So I think those are some of the biggest difficulties. Is really a little bit of kind of where this new specialty and what exactly do we do and what is the extent of what we can provide for patients and family. And I think another barrier is that we kind of are a difficulty is the difficulty with access. It's a relatively new field. There's not enough palliative care providers to always see everybody or have a clinic available. It's expanding rapidly, which is really exciting to see, but a lot of patients may not have the opportunity to go in person. So that's where maybe telehealth comes in. That comes with partnering with other providers. And I think what's been exciting in the field is that we're seeing a lot of clinicians or physicians, for example, who are oncologists who are getting the training and getting the subspecialty in palliative care. Or we're seeing somebody who's a psychiatrist getting palliative care training. So there's a broad emergency room doctors going and getting the palliative care training. So you're seeing this complementary training and this extra support being integrated right into the care that's being provided. Well, thank you everybody for your time, and I really appreciate your questions, and I hope you enjoy the rest of the conference.
Thank you very much.
Thank you.